All right, this is Sherry again, welcoming you back to the second half of the secondary assessment lecture. We'll try and get through this pretty quickly. This is a long topic, but we'll try and get through this as quickly as we can. So we're going to talk about a little bit about the secondary assessment of the trauma patient. So injuries the trauma patient can be somebody that twisted their ankle all the way up to a crushed person that's crushed under an I-beam or under a fallen car. So we want to determine how serious this injury is. So first thing we want to look at really is the location of the injury or the injuries and where they're at. Obviously, a leg injury or arm injury is not going to be nearly as severe as an injury to the chest or the head. So we want to look at the location. We also want to look at the patient's mental status. If they're able to talk to us, they know where they're at, person, place, and thing, and they're able to mentate, then we know at least they have enough blood flow to be getting oxygen to their brain, and that is a good thing. So we will be taking care of that. Then we're going to look at basically our ABCs. Does our patient have a patent airway? And do we think it's going to stay open? Or is there a risk that it may close or be in jeopardy, say with blood? Or do we have bleeding into the airway? If so, that's a problem. We want to look at our vital signs and see where we're at there. We also, and this probably I think should be at the very first part of the list, is looking at the mechanism of injury. How much force was involved in this injury? Obviously, if you have a let's say car versus telephone pole at 15 miles an hour versus a motorcycle that's hit by a semi, there's a much greater mechanism with one of those, or much greater force with one of those than the other. So we would expect more injuries. So we want to look at that force or that mechanism that's involved. And then we want to look at the patient's age. I think we'll all agree that older patients, our geriatric population, has less capabilities of compensating through a severe injury or illness than somebody that's younger and healthier. So we want to look at that, and we want to look at pre-existing medical conditions to see if there's something that's going to inhibit our patient from being able to work through this. Okay, so once we consider all of those factors, then we want to focus on the area that our patient tells us is painful, or the area that, based on the situation, our mechanism of injury indicates that we should look at. So if you've got a little kid that is crossing the street and hit by the car, that bumper, say, hits him in his abdomen area, then we want to focus there and consider some other areas. So we have to tailor our assessment based on what we find. Okay, so first of all, figure out what is our chief complaint. Okay, get a history and get a little bit of background on how this happens so you can kind of wrap your brain around what injuries you need to be looking for. Now, I will tell you this just as a thought to ponder. Frequently, when you have very severe injuries, your body shuts off the pain receptors because it overwhelms the brain's ability to cope. So if you're getting so many pain receptors triggered, the body basically just shuts those off and says, we're not going to deal with those right now because I have other things I need to worry about. And your patient will not feel pain. I had a 16-year-old boy. His car, he fell asleep while driving. His car was hit broadside by a semi. When we got there, the semi was in the ditch. Half of his car was in one side of the road ditch, and the other half, the transmission, etc., was across the street in the other road ditch, and his car frame was sitting flat on the pavement in the middle of the road. And we were pretty sure that nobody would have survived this. When we walked up to the car, I see his femur bent in half and sticking out the driver's side window. And this kid is talking to me. So I crawled in the car with him. His only complaint was that his right hand hurt. And there was a little swelling in his right hand, but he was moving all of his fingers and everything, but he said his hand really, really hurt. He did not feel any pain from that femur, nor did he feel any pain from his feet that were impaled in all of the pedals down there. So you can't 100% rely on their pain, but that's a good place to start. But don't rule out other injuries based on that. Okay, so the chief complaint is what the patient tells you is going on, or what the patient tells you the problem is. Okay, so we also want to look at the force involved, the direction and the strength of that force, and then what we would expect the body's response to be from that. We also want to look at protective equipment. Were there airbags involved? Were there side bags, front bags? Were they wearing a seatbelt? Did they have a helmet on? Was the child in a child restraint car seat? Was it restrained properly in the car? So all of these things. On a motorcycle, did they have flip-flops and shorts on, or were they wearing leathers and boots? Okay. We want to take some action based on all this that we're gathering very quickly. Take some action to prevent further injury, and then we want to address those areas of pain. Okay. So our mechanism of injury needs to be compared to our potential injuries, and we need to do a thorough inspection of those body systems to make sure we're not missing something. So to do that, we're going to do the same way we did our medical patient. We're going to observe. We're going to look for signs of injury. We're going to feel for signs of injury, and when we're palpating, we're also seeing if it stimulates any painful response from our patient. And we're going to listen. So again, we want to listen to lung sounds. We want to listen for difficulty breathing, if they're wheezing or gasping or gurgling. We want to know that. We also want to listen for other sounds like, you may hear, well, I don't know, it would be pretty difficult to hear bleeding, but listen to those sounds that, with the lung sounds that would, or the lack of lung sounds would another thing that we would be interested in. Okay, so do a physical exam. Okay, look at those systems, the respiratory, the cardiovascular, neurogenic, endocrine, GI, reproductive, and gastrointestinal that we talked about. Okay, we're going to look for abnormalities in symmetry. Symmetry means, is it the same on one side as it is the other? So that's really important when you're looking at the face and head. They should be the same, relatively, unless they're normally not the same. So looking at those, looking at the way a limb is angulated, or the length of a limb. When you're looking at legs with femur fractures and hip fractures, frequently those limbs that are fractured will be shorter or turned outward when compared to the other limb. So looking to make things are the same. Look at the chest rise and fall. Is it the same on both sides? If you've got a collapsed lung or something that penetrated through and has a hole in the chest, you may not have chest rise and fall the same on both sides. Okay. We're going to look at our color. So this isn't looking at the patient's skin on their face and determining are they pale or cool. We want to look at the color and temperature of the skin on all of our extremities, because we may have a face that's pink, but we may have a leg or an arm that is pale and cold, which means they're not getting circulation to that extremity. That is a big deal. Okay. We want to look to see if there's deformities, if things are misshaped. We also want to look to see that they can move everything correctly. So we're going to feel for abnormalities in the shape. We're feeling again for that bony crepitus. We're feeling for swelling. We're feeling for deformities under the skin. Most fractures do not break through the skin. So most of the fractures you're going to come in contact with will have a slight deformity But oftentimes you have to look for them. It's not something that's just, things are bent at a 90-degree angle. It's just a very small deformity that's going to indicate that there's a fracture there. We're looking for temperature. What is our skin like? So if we have a fracture in our femur, I want to know what the temperature is in my toes. Am I getting blood flow to the bottom part of that extremity, or am I not? If I'm not, I'm going to have pale, cool skin down there. So I want to look for that. I want to look for texture. Do I have any bony crepitus? Is it like crunchy under the skin? Looking up at the chest and the neck, sometimes if we get a tear in the airway, we will have what we call air crepitus or subcutaneous emphysema, and it's air bubbles under the skin that have air that has leaked out of the airway and it's now found its way under the skin. When you feel it, it kind of feels like Rice Krispies under there. It's kind of crunchy. So that would be a texture. We want to make sure that they're neurologically intact, that they can feel all the extremities, and they've got good sensation. Okay. Again, we're listening with our stethoscope and our ears, but we're looking for decreased breathing, decreased air movement, or absent breath sounds any place in the lungs. Okay. And here we talked earlier about DCAP BTLS. Here it is written out. So DCAP BTLS are things we're looking for as we go from head to toe to indicate an issue that we need to address. So D is deformities. C is contusions. Those are simply bruises. Abrasions. We see these a lot, particularly with motorcycle crashes. We get a lot of road rash. Can it be significant? It can, because it indicates that there was a force there. So if we have a contusion to the head, we know there was a blow to the head, and we want to start looking for head injuries. Okay, so oftentimes we think abrasions are kind of insignificant, but they are indicators that we need to pay attention to. Punctures and penetrations. As we move into trauma, you're going to learn how to deal with these. But punctures and penetrations are significant, and we need to, even the smallest puncture. For those of you that are familiar with guns, a .22 bullet is very small, and it will leave a very, very small entrance wound, and frequently, because of the speed that it goes in, kind of cauterizes those vessels and oftentimes doesn't bleed. So you have a gunshot wound coming in, and .22 is not a very high caliber, so it very possibly can bounce around inside your system if it hits a bone and deflect around and not come out of the body. So you may have this .22 shell that's bouncing around in your body, penetrating all kinds of organs and vessels, and the only indication you have of that is a very small, less than a pencil-sized eraser entrance wound that doesn't bleed. So the smallest of puncture wounds could be very significant. We're also looking for burns, whatever degree. We're looking for any place that is tender, lacerations or cuts of any kind, and swelling. So after we do that, we're going to get our baseline vital signs. We're going to try and get a good medical history, because if we have a patient that has medical issues, this is probably going to play into their ability to recover from this injury. So we want to get a good past medical history. We also want to find out if they're allergic to anything. We want to find out when they ate last, because if they're going to surgery, this is something that the surgical team needs to know, if they've recently had anything to eat or drink. So we're going to use that sample history to obtain all those answers that we need. And we want to do this quicker rather than later with these patients, because if they deteriorate and they lose consciousness, we don't have the ability to get this information. Okay, so a sample history, and we went through this before, signs and symptoms, allergies, medications, so all of that. Pertinent past history, one thing I didn't talk about earlier, but would be a family history. We want to know what their medical history is, but we also want to know family history. Did they have a father, mother, brother, sister that died at a very early age? Do they have a history of heart disease in their family? We also want to know if they're a smoker, okay, or what their alcohol intake is, if you're of concern there, if they have dependency issues, that may also play into their recovery. So if our mechanism of injury, our history, or our signs and symptoms on our physical exam indicate that there may be a spinal issue, then we want to make sure that we put on a C-collar. So the C-collar is not stabilization of the spine. Okay, we want to stabilize the spine manually, like we are here, and then we want to measure from the jaw down to the collarbone to get our size. So we want the correct size C-collar. Okay, then we want to put it in place. Make sure it's right side up. I can't tell you how many of these C-collars I've pulled off of people because they were placed on upside down. Take a few minutes and make sure that you know you're doing your job correctly. There's a little divot place for the chin, and that's where the chin needs to sit. Okay, so put the C-collar on, and then continue to hold manual stabilization. We're going to hold that until we get our head stabilized to the long spine board. Okay, so we're going to reassure our patient. Take jewelry off that might be there, particularly earrings. If my patient has clothes on, I tuck that jewelry in their pocket. I don't want to hold it myself. I don't want responsibility for it, or I give it to a family member or law enforcement. Okay, so put their C-collar on, as you see here, and manually stabilize. Okay, then we're going to consider ALS. If this is a situation that we feel ALS would be advantageous, we want to get them called sooner than later because they're going to have some travel time. Okay, and do that rapid trauma assessment. Now, wouldn't it make sense to inspect and palpate the neck prior to putting on the C-collar? So if you know you're going to do that, put your C-collar on after you've already looked at the neck, and you don't have to take it off to look again. Okay, so our rapid trauma assessment is we're doing that quick ABCs, boom, 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 and then we're going to look quickly at each part of the body. So from the head, we're checking for wounds, tenderness, all of those things we talked about before. We're actually feeling in the head. For somebody that's got dark hair, there can be a lot of blood tucked away in their hair, and you don't even realizing they're bleeding. So put your fingers in there, palpate that scalp, and then look at your gloves and see if there's any blood on your gloves. For those of you that have departments that have black gloves, that's going to be harder to do than if you have a lighter colored glove. But look for blood, look for deformities, look for soft spots. Okay, then we're going to go to the face and do the same thing. Okay, so we want to do this quickly on scene so we know what we're dealing with, but we don't want to delay transport very much to do this. So you should be able to do this in just about a minute, 2 minutes to max. Okay, so palpate the face, ears, eyes, nose, mouth. Look in the mouth to see if there's any broken teeth, blood in the mouth, blood in the airway. Sometimes you have patients that bite their tongue, bite the inside of their face or their cheek, and they have a lot of bleeding in there, in which case we want to start thinking about suction pretty quickly. If there's anything in the airway, we want to suction it out or get broken particles, or maybe there's food in their mouth. We want to get that out so that our airway stays open. Okay, we're looking at the eyes and ears to see if anything's coming out of the ears, fluid of any type. Okay, clear blood can sometimes be cerebral spinal fluid, which is the spinal fluid that goes around the spinal cord and brain. If that's leaking out the ears, that's kind of a really big deal. So look at the neck, look for wounds. The neck is really important. There's a lot of airway structure and a lot of big vessels in there. So if you've got an open neck wound, that needs to be covered immediately. If it's a full thickness laceration, that needs to be covered first with your gloved hand and then with an occlusive dressing. And we'll talk about those, but it's a non-permeable dressing of some kind, whether it's your hand, a Vaseline gauze, something like that. Okay. We're also looking quick for that jugular vein distension. We're looking to make sure the tracheal is midline, and we're looking just to make sure they don't have a tracheostomy or stoma or a breathing tube in their neck. Okay. And quickly, listen to breath sounds. We want to do that before we leave because we cannot hear that bouncing down the road. So we want to make sure they're equal, they're there, or they're not there. Okay, here we're going to go right down. Apparently I didn't move this very good. And check the chest. So we're looking at the chest. We're checking the integrity of the chest wall here. So I'd wrap my hands right around here and squeeze inward to see if my ribs are intact. Okay. Lung sound should be checked there. And we're also checking here on the chest for any open wounds. Open wounds in the chest, we're going to assume that is probable cause for a collapsed lung. So if I have an open wound, we call those sucking chest wounds, that air is moving in and out, immediately you put your gloved hand over that. That is an airway issue. Put your gloved hand over that, and then that needs to be sealed as quickly as we can get it sealed with an occlusive dressing or a non-permeable dressing to keep air from getting sucked into that chest cavity and filling up the place in the chest that the lungs should be in, because that outside air will collapse that lung. Okay. So we're looking for ribs that move in a different motion than the other ribs. We're looking for that bony crepitus, and we're looking at the skin. This can't be done with the clothes on. There's a term that we have in EMS, and if you've got a trauma patient, they probably need to be trauma naked. So get their clothes off, cut them off, and take a quick look. Be what do I want to say here? What's my word I'm looking for? Don't just rip their clothes off and leave them naked laying there on the street. Have a blanket there. Or if you cut down the sides of their clothes, you can fold them over, take a look, and then fold them back over so that they're covered. First of all, we don't want them getting cold. Second of all, we do really need to protect their privacy. Okay. Abdomen, we talked about that. We're pressing down on all four quadrants with the full flat part of our hand, fingers and palm, to make sure that we're not just touching small areas of the abdomen, but we're touching and palpating all of the abdomen. Okay. We're going to check the pelvis. We're going to push down on the sides and wrap your hands around the sides of the pelvis and pull inward to make sure that it's stable. Okay. Priapism is that erection that we're looking for, especially in our unresponsive patients. So if there is an erection there, that is a sign of a serious neurological deficit, and we need to make very serious note of that and pass that along very quickly. Okay. Look at our extremities. Obviously, there's much less life-threatening stuff in the extremities than there is in the trunk of the body, but they could certainly bleed to death from an injury in the extremities. So we need to take a look at those as quickly as we can once we get through the abdomen and chest. Okay, so there's this palpating the abdomen with both hands on both quadrants, just like that. Okay. So on the back, we're going to log roll the patient onto the side, look at the back. I do that right before I put them on the lung spine board. Run my hand down the back. I'm looking for bleeding. I'm looking for deformities, all of that stuff, swelling, tenderness, blah, 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 before I put them on the back. I don't want to have to take them off the backboard to do this again. So it's easy to forget this, so make yourself practice this so that you don't forget when it comes to real life. Okay, and then get a good set of vital signs. So here they are palpating the posterior backside of this patient before they put him on the lung spine board. Okay. Communicate with your patient. Okay, if your patient is responsive, they're going to be afraid. They want to know something. So tell them what you are doing. Tell them what you're looking for. You can tell them what you find, not to frighten them, but to keep them in the loop. Okay, we're going to assume a spinal injury until we have reason not to. Okay, so if we find a life-threatening issue, we're going to stop. We're going to treat it before we move on, much like the open neck wound or the open chest wound. Okay, so maintain eye contact. Frequently speak with your patient so that you can know what his mental status is. If it's changing or declining, you want to know that right away. Best way to do that with your responsive patient is to talk to them. Okay, so we want to check, this is kind of a long checklist, but we want to check what I call CSM, or some people call it PMS. You want to check sensation, can they feel? You want to check motor movement, can they move their extremities? And you want to check circulation. So CSM is circulation, sensation, motor. PSM is pulses, or PMS is pulses, motor, and sensation. Whichever acronym you use is fine. They do the same purpose. So I check in the hands, squeeze my fingers, move my fingers. Can you feel me touching? Check a pulse. I do the same in the feet. So you want to make sure that you do that. We talked about that in the last lecture. And make sure that they've got good function in all of their extremities after you have checked the trunk. Okay, so with our little kids, lesser mechanisms of injury can cause more significant damage because they don't have as much body mass and they're smaller. They don't have hard bones for protection. Their bones are still very supple and bendable. So in our kids, they also have a much greater ability to compensate. So they will not look sick or hurt for a much longer time. But once they start to deteriorate, they're going to drop like a rock. So take very good note of your kiddos. Okay, so the detailed physical exam almost always is done en route. I do a detailed physical exam on my trauma patients as well as my medical patients because there is no reason to miss something that you might have picked up if you'd have just done the assessment. If you don't do it, they're going to do it in the ER, and you're going to look very foolish if there's something there that you didn't find simply because you were too lazy to do a full detailed assessment. So the detailed assessment reevaluates again. So we do the quick check with the primary assessment. We go back to the secondary assessment and focus on that area of concern. And this detailed assessment is absolutely head to toe to check everything out and make double, triple sure we didn't miss anything. Okay, so with our medical patients, there's probably not a need to take all their clothes off. With a trauma patient, that need might be there to do that. So again, we're going to go right through and just looking for things with our medical and our trauma patient. We will have done some of this if you've done the rapid trauma assessment, but in our detailed, we're going to redo a lot of it. Okay, this is after the primary and secondary. If you do this prior to, well, you're going to fail your National Registry exam, but you're doing things out of order. Your priorities are not in sequence, and you're going to miss a big thing. If you're busy assessing if there's fluid coming out of the ears and you've missed the fact that they're not breathing, that's not acceptable. So we're going to expose our patient, especially if they're trauma. Okay, we're going to work around our immobilization equipment if it's there, and we're going to go from head to toe. So keep a high index of suspicion. Be aware of the patient's fears. Be aware of their emotional support. You can explain everything to them. But you know, when you do a good assessment like this, they feel like they're getting really good care from you. And that's exactly how they should feel. So if I've got a patient that only has a sprained ankle, then I'm not going to be in quite such a big hurry to do the detailed. But I'm still going to do it. I've got time en route. Once I've got their ankle stabilized, I've got time to do this. Why not? Okay, so this gives a chance to ask some more questions, to assure them that everything that you find that's normal is normal, and that's a good thing, to give them that positive feedback to kind of help calm their fears. Okay. This one says, is it necessary to always complete a detailed assessment on a trauma patient with no significant mechanism of injury? My answer to that is yes. You might find something you missed before. Okay. Gather a set of vital signs and go down through There's a lot of stuff in here that we've already discussed. So if they have a significant mechanism of injury, we're going to continue their C-spine control and control their head and neck movement. We're going to call ALS if we need, if it is significant. With a significant injury, there's nothing magical that ALS is going to do, except, we could get an IV started. We could help maintain their blood pressure to some degree. But pain meds is a big thing. If we can get pain meds on board, it's going to really help them get through this. Your job would be to take care of that stuff, get ALS en route, and then get a good history from them and perform that rapid trauma assessment. Okay, I'm going to skip through this review here quick. And we're going to go to the reassessment. Reassessment, once we've done that primary, secondary, and full detailed assessment, then reassessment is going to give us a lot of feedback on how well our interventions are working with this patient. Because if they're working good, we need to know that. But if they're not working, we need to know that, and so do the people that are going to assume care for this patient. Okay, so we're going to go back through and redo our initial steps of the assessment. Okay, we're going to keep monitoring those ABCs. You are never, ever, ever going to get dinged for checking your ABCs. If you get to a point you really don't know what to do, go back, look at their airway, look at their breathing. Is it adequate? Is it changed? Look at their circulation, check a pulse, check a blood pressure, and see if anything is changing. Okay. Our reassessment is probably one of the most important things we can do, because this is where you're going to realize if a patient is going into shock, or at least decompensated shock. But you can definitely, this is where we recognize shock right away. So we never want to skip the reassessment. And when you call in your patient care report, you need to include your reassessment, how your patient has responded to the treatments you've given. Okay. So it identifies any changes, both little and big. Okay. With shock, you're going to find when they go into shock, you're going to see the pulse rate go up. It may not be much, but if it's going up and you've got them in the ambulance and you should be calming their fears and their pulse rate still going up, you have a patient in shock. And as we get further along in our studies, you're going to find that shock is the element that kills people. All of us are going to die from shock. So although that's a very subtle little change, it's huge. So we're going to start trending our vital signs so we can recognize those things. We're going to start recognizing deterioration before it gets to the point that we have an unresponsive or pulseless apneic patient. We're also going to recognize if things are starting to improve. So communicate with your patient, explain the process. The reassessment is going to be rechecking those ABCs, rechecking vital signs, rechecking perfusion status. We're going to be talking about our patients' feelings and explaining things to them and trying to make them as comfortable as possible. Okay, so again, make sure our airways are open, looking at our breathing rate, quality, looking at our pulses. Are they changing? Are they different? Maybe check a blood pressure in the other arm this time. Again, look at our skin color and our temperature. Is our patient becoming more sweaty or less sweaty? Is he more pale than he was before? Or is he pinking up and looking good? Okay. This is the time when we may say, you know what, let's kick this into high gear and let's go back to the hospital code 3. I really don't like how this patient's going. Or his heart rate has gone from 60 to 40 and his mental status is declining. I'm not comfortable with this. Or if you've got a patient that you're ventilating and all of a sudden he's very difficult to ventilate, then that's a significant change and we need to recognize that and reestablish our transport decision based on that. Pediatrics, we want to first, see if we can shout at them and stimulate them verbally if we can't, especially with our babies. Flicking the soles of their feet, just thumping or flicking the soles of their feet is a very good way to try and stimulate them. If our kids cry, That's normal. That's what we want from them. It shows that they've got good air movement. It shows that they're responding to strangers appropriately, and they're doing okay. So not everybody's mental status is going to be the same based on their age, but if we can recognize what is normal for that age range, we can recognize what's normal and what's not. Okay, so as we trend those vital signs, we want to be looking at them, writing them down and documenting them so that we can trend them. And those need to go with us into the ER and hand it off to the care team there. Okay, relook at our oxygen saturation, and that's going to be pulse oximetry, it's going to be pulse rate, it's going to be skin color, it's going to be lung sounds. Okay. Alrighty, so we're going to keep repeating those as we go along. If we're going along and we find out that the 4 liters of oxygen that we have our patient on doesn't seem to be helping as much as we would like, so we bump it up to a non-rebreather at 10 liters per minute, then we need to reassess a couple minutes after that to see if the 10 liters is making a difference or not. Okay? We can do this by asking our patient questions. Do you seem to be breathing easier? Do things hurt as bad as they did? Anything changing? How are you doing now? And just asking those questions, keep them in the loop. So if we found an issue, we need to go back and keep checking those issues to see how they're doing. Okay? We also need to make sure that we're getting enough oxygen delivery. And to do that, we're going to be looking for signs of shock as you learn further and are able to recognize those signs of shock. But your baseline vitals are going to tell you that and how they're trending. We know if your pulse becomes weaker, you're probably losing blood pressure, or if your blood pressure starts to drop into an area that is lower than normal, that the ability for the body to get oxygen to the brain is going to decrease, because our blood pressure is the force that drives the oxygen to the brain. So if we don't have enough pressure to move the red blood cells around in the system, we're not going to have oxygen getting to the brain like it needs to be. We also need to look at bleeding. If we're bleeding our red blood cells out, we're going to have a problem with our oxygen. So we need to control bleeding as quickly as we can and make sure that it stays controlled. Okay. So there we are in the back of the squad doing exactly what we need to do. Okay. We talked about trending. So past those trending vital signs, if the vital signs are staying stable, let them know. Vital signs are stable and remain unchanged. If they are changing, let them know when you call in your patient care report. Okay. So we're going to look at our patient's condition, consider how much time we're going to have with our patient, and make a plan on reassessment and interventions. Okay. Obviously, if we've got a patient that's unstable, we want to reassess at least every 5 minutes, and maybe kind of continuously. You may want to put somebody on monitoring that directly, or hook them up to your monitor where you're monitoring the pulse off of your cardiac monitor or your pulse oximetry, that maybe you have a continuous pulse oximetry reading, or maybe set your blood pressure cuff on your cardiac monitor if you have such an availability to take that blood pressure maybe every 3 minutes, so that you're getting a constant feedback of what's going on with this patient. So every 15 for stable, every 5 minutes for an unstable or potentially unstable patient. Okay, and we can always bump that up. Just because this patient is stable doesn't mean we have to wait 15 minutes in between. That's the longest we want to wait. It's absolutely appropriate to check beforehand. Okay. So our critical thinking is something that you guys have to learn to build. And hopefully, as we run you through scenarios and things when you come to your lab, you're going to be able to build this critical thinking. Okay. So in our critical thinking, what we'd like to do is do a field diagnosis. And everybody says EMS doesn't diagnose, but quite honestly, diagnosis is a label for a condition. And it's based off of history, what you find on the physical exam, the vital signs, and the history that they tell us. That is what a doctor does, is he takes all this, puts it together, and says, this is what I think's wrong with you, and calls it a diagnosis. We do the same thing in EMS. We call it a field diagnosis because we don't have all of the assessment tools that a physician would have, such as lab and x-ray, things like that. But we certainly can come up with a potential diagnosis or something that we suspect is wrong with the patient. Okay, so we want to interview our patient. Obviously, clinicians have different levels of training, and they all have different techniques, but they all have a systematic way of coming up with their diagnosis. Some people, I go down when I'm doing my evaluation, I am talking to my patient, I'm having my partner get vital signs, I'm going down through and checking, starting at the head, going down, check the legs, I do the arms last. If you want to go down through and check down through the pelvis, come back up and do the arms, and then check the legs, that's fine. You're getting it done. Just always do it the same way so you don't forget something. Okay. So what we're looking for, and this is how I like to do it, is I want to put a box up there in my brain. And in that box, I'm going to start throwing all the things in that could potentially be wrong with my patient. Now, you can do this before you ever get to the patient. Okay, and I call these differential diagnoses. So if I go to a call, and my call is a 4-year-old with a seizure, why can't I start while I'm going there thinking, what could cause a seizure in a 4-year-old? Okay, it could be a febrile seizure. He could have a fever. He could have epilepsy. He could have a head injury. He could have, start listing those things that would cause a seizure. And then when you get there, you've got stuff in your box, and with your assessment process, we may be able to throw some of those things out. It's like, okay, he doesn't have a fever, so throw that one out. He doesn't have a head injury. He's not bonked his head. There's no evidence of head injury, so let's throw that one out. So then we're left with a couple little things, which is way better than the maybe 8 or 10 that we come up with. So as our assessment continues, we're able to decrease this number of differential diagnoses down to a few, or maybe sometimes one, that's going to help us understand what's wrong with this patient. So we're going to quickly rule out the life threats, okay, stabilize our patient, focus on the worst case scenario first. So if I've got a patient that's got chest pain, I'm going to assume that this is a heart attack until I have reason to believe otherwise. Okay? So if I'm assuming it's a heart attack, that means I'm going to get ALS en route. I'm going to transport this patient immediately. And en route, if I reach up and I palpate his chest and he screams because when I palpate the 2 ribs on one side, it recreates that same pain he's feeling, maybe this isn't a heart attack. Maybe this is a cracked rib. So on history, maybe find out what's been going on. And yeah, he did crash his bicycle earlier today, or he did fall off the kitchen chair, or whatever. And there is an injury there. Then maybe we can say, well, I'm going to think maybe this is maybe not so much cardiac and more muscular. Okay, but we're going to start with worst case scenario. We're going to basically do the same things an emergency doc's going to do. Okay, emergency docs are very busy and they don't have a lot of time, so they are very quick and thorough with their assessments. We are the same way. We don't have a lot of time. We want to get these patients to the ER, especially trauma patients, as quickly as we can. So we're going to look at the serious conditions. We're going to do that quick, thorough evaluation and then start ruling things out. This helps us create a diagnosis. This is where the critical thinking comes in. Anybody can memorize if I see this, I need to do this. But when you start integrating a cardiac situation with a respiratory situation, or you start integrating a head injury patient that they've sustained a head injury, but they already have, let's say, cystic fibrosis, where they have breathing difficulty already. We're going to have to understand what is normal for this patient, or is the breathing irregularities that we're seeing associated with a head injury, or is it their medical condition? So this is where the critical thinking comes in, and this comes harder because we can't write this all out in a textbook. It's something that you have to learn the process of thinking to learn. So it's starting this evaluation process early and learning how to recognize signs and symptoms for things, but it's not always black and white. Sometimes there's some gray in there, and we need to be able to know what our limitations are and what we're seeing and what we're not seeing, and try and get this broken down to something that's manageable. Okay. So we have to organize the data in our head. Okay. We have to learn how to organize that, and we have to learn how to process through that in an organized and quick fashion. Okay, this is going to mean we have to change the way we think. Okay, we can't, as EMTs, memorize this. We have to be able to critically think. Okay, and I found by hanging out with people that were great care providers, I was able to pick up on some of the ways that they were great care providers and emulate those and learn from them. So pick and choose who you learn from. If you've got people on your department that take lots of shortcuts, really don't provide a lot of patient care, and they're more of a scoop 'em and haul 'em kind of a provider, then maybe that's not the best person for you to spend your time with. You want to seek out those people. I tell you, the best learning place I had was in the ER. I worked in a hospital-based service, and if I wasn't working on the ambulance or had another duty that I was doing, I was hanging out in the ER because I wanted to be side by side those docs and see how they did and learn things from them that I didn't already know. This is medicine. It's a constantly evolving field, and if you can embrace that learning process, you're going to be well ahead of people that don't. So learn from others. Sometimes the process is trying to reflect on, wow, I really screwed that up. That is a huge learning. I can tell you very quickly on a handful of times when I screwed up and I wish I could go back and redo something. Sometimes it wasn't a big deal. It wasn't detrimental to the patient, but I know in my head I didn't recognize that as quickly as I should. But those are learning opportunities, and I have not ever repeated any of those since because it impacted me that I did not recognize something I should have. Okay, so we make diagnosis in the field. Okay, they're not going to be as extensive, but they guide our treatment plan. So we need to have the ability to make a list of possible diagnoses, make a competent assessment to be able to rule some of those out, narrow that list down, and then base our treatment plan on those diagnoses that are left. Okay, so again, we want to get them to a higher level of care as quickly as we can, but we can do a whole lot of diagnosing and assessing while we're in the process of moving them. So we don't want to delay treatment, but we certainly do want to do a good job. Okay, that is all I have for you guys. I hope this has helped a little bit, and we will talk to you again soon.